Good morning, everyone. I'm Dr. Tara Kieran. I'm a family physician at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at U of T. I'm delighted that our department can bring you these series together with the Ontario College of Family Physicians, and I'm going to turn it over to their president, Liz Muggah, to give a bit of an introduction. Liz?
So good morning, everyone. Delighted to have you joining us here. We've got a great panel today with Dr. Kieran Moore, Dr. Janine McCready, and Dr. Dan Warshafsky. So more very soon from each of them. And just a reminder that this is Maine Pro accredited. So details about that are on this slide and will be emailed to you. And the next slide, I'll read the land acknowledgement. We acknowledge the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. And I invite all of us to reflect on the territories that we're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And also as a leader, I commit myself to the work that we need to do together on this path towards reconciliation through the college and our work there. And I'm calling in from Ottawa, which is unceded Algonquin Anishinaabe territory. Over to you.
I think many of us know that, unfortunately, Indigenous populations in Ontario, especially in urban areas, have a lower uptake of first doses. And I know many of our colleagues are working hard to try and support a community-based approach to that. And if you want to learn more about how you can support vaccination for Indigenous populations, highly recommend this webinar that's being put together by the Indigenous Primary Healthcare Council here in Ontario. Next slide. So as usual, I just wanted to remind you that this is one of a series. We've been talking now about the kids' vaccines and third doses for several weeks. And please, if you've missed our previous sessions, take a look at them at that website that Mina has also posted into the chat. You can hear from experts like Jeff Kwong, Alison McGeer, Epson Allen, and fellow family physicians who've been doing fantastic work in their communities getting ready for COVID vaccination for kids. Next slide. So I'm delighted to introduce our panelists, or I'd rather have them introduce themselves. Next slide. Next slide. Special thanks to Dr. Kieran Moore for joining us today with everything going on. So Kieran, I'll let you introduce yourself first.
Good morning, Kieran Moore. I'm a salaried employee of the Ministry of Health, the Chief Medical Officer of Health. I have received grants in the past from the Canadian Institute of Health Research and Physician Services Incorporated, mainly to deal with the epidemiology of Lyme disease. And I received a one-time honoraria from Pfizer to review the epidemiology of Lyme disease in Canada. Otherwise, I have no other disclosures and can hand it over.
Thanks, Kieran, for being here today. Janine?
Morning. Thanks for having me. I'm Janine McCready. I'm one of the infectious disease doctors at Michael Garron Hospital here in Toronto, and have been doing everything inside and outside the hospital related to COVID in our community and working with the schools. And I have no disclosures. Thank you.
Wonderful for you to join us again, Janine. Thanks. And Dr. Dan Warshafsky is going to be joining us at 8:30. So Dr. Moore will be with us from 8 to 8:30, and then Dan Warshafsky will be from us from 8:30 to 9. And he doesn't have any disclosures at this time, but I'll ask him to speak to that when he joins. Next slide. And so, of course, we've got our great co-hosts, David Kaplan and Liz Muggah. David, did you want to introduce yourself?
Sure. Yeah, for sure. Thanks. I'm David Kaplan. I'm a family doctor and the Vice President of Quality at Ontario Health, and where I receive a salary support. And I receive an honorarium for the OCFP. Glad to be here again this morning.
Liz?
Hi, Liz Muggah, family doctor from Ottawa, and I receive a stipend for my role as president of the college.
And I'm Tara Kieran and have received grants and salary awards as well as honoraria that I've listed there. The only one from a for-profit company is Gilead Sciences for some work related to hepatitis C. Next slide. So delighted, of course, to have all of you join us from across the Greater Toronto area and far beyond. So wonderful to see all those places that you come from. Next slide. When you register, you submit questions that you want us to discuss, and we take that very seriously in planning our session. And of course, you guys wanted to know the latest on Omicron. You wanted to have an update on some of the third dose decisions. You wanted to get some advice about how you can advise patients related to holiday gathering. And of course, there continue to be questions about vaccinating kids 5 to 11. So those are some of the topics we'll be covering today. Next slide. But at the same time, and I think all of those topics are even more relevant today as we see that there are, increases in cases here in Ontario. So that's the red line that we've shown this graph before, thanks to Jennifer Kwan. And that red line is cases that are consistently going up now. Thankfully, the new deaths in the blue line are not. But I know all of us are particularly worried about those topics in this context. Next slide. But today's session, although we have some, I think, prepared remarks from our speakers, a lot of it is going to be driven by you and the questions that you asked during the session. So that's how we've designed today's session. So please do put your questions into the Q&A box. Please don't put them into the chat. Please put them in the Q&A. Please take a look if there's already a question being asked that you agree with, and then give it a thumbs up. Basically, I'm going to prioritize the questions that have the most thumbs up. Please take a look also at the answered column, because our panelists do an excellent job of answering questions through typing, and your question may have already been answered, so please take a look at that. And of course, if you want to share resources, thoughts, or reactions, use the chat to do that. We love to hear your reactions and learn from you as well. And the chat is a great place for that. But please put your questions in the Q&A. Next slide. So without further ado, what I'm going to do is I'm going to turn it over to Dr. McCready to just give us an update on where we're at with Omicron. Next slide.
Perfect, thank you. So next slide, please. So we're going to talk a little bit about this, but I think the most important thing is this is very new. So everything we talk about today, it is evolving very quickly, and we're literally getting new data, and the researchers around the world are pulling things together, and we're learning more kind of by the hour. And so one of the slides that I sent in yesterday, that's already been updated by someone, today. So things are really evolving quickly. And I think this is a nice table that the public health PHO put together, and to highlight the degree of uncertainty for all of these things. So are we sure of anything at this point? Not really. So we know that we need to be aware, and we know we need to pay attention to this, but we actually are still learning more very, very quickly. And so these are the main issues when we think about a new variant, and how does that affect us? How does that affect our plans here in Ontario? And we're very lucky to have Dr. Moore here to address some of that and some of the steps that the province already has put in place to kind of decrease the spread of this variant. So the first issue is importation into Ontario. So we already know we have cases here in Ontario. There have been cases reported in Ottawa, and then yesterday there was another case reported in Durham, who actually is someone who works at the Toronto East Detention Centre. And now there's a confirmed outbreak of at least 5 people as of yesterday at the Toronto East Detention Centre. So we expect there to be more cases. This is not unexpected. And earlier in the week, cases seemed like they were very centralized in South Africa, but now the map of the world has lit up with people that are reporting them. And I think the United States is up to 8 cases, but it's just because they need to look further. So really, this is likely very widespread at this point, and things like travel bans are not going to do much to, some people said it's like closing the barn door after you've already let everything out. So certainly there are cases here, and we will see more. In terms of increased transmissibility, this is a big concern, and what we have seen out of South Africa is that the Omicron variant is outcompeting Delta. So do expect that it is increased transmissibility, and it's likely a combination. So there was a preprint just put out yesterday that it's likely a combination of increased transmissibility and then some degree of being able to evade immunity from previous infection. And that's what's leading to these increased infections within that we're seeing in South Africa. So in the population of South Africa, we don't actually know if that's where Omicron started or if that's just where we've now found it, because they have a very robust program for sequencing and picking up new variants. So in South Africa, it's an interesting population because they've had about 24% of their population immunized, but based on modeling, it's expected that probably almost 100% of the population has had COVID at some point in the last 20 months. And that's based on the fact that they've had about 230,000 deaths from COVID. So if you estimate that out, most people in the country have likely already had COVID. So if you take those numbers and then you see how rapidly Omicron is spreading, it seems that from the study, the modeling that they've done over the last few days, is that Omicron does have an increased risk of reinfection and some degree of immune evasion in people that have had previous COVID. So we don't know what that looks like for people that have been previously vaccinated yet, but certainly people with previous COVID, it looks like they're more likely to get infected. So that's one thing that is, seems to be pointing in that direction. The question of whether the vaccines will still be effective, we are still learning about this. The expectation is that they will still at least have some impact, certainly against severe disease, and likely will still reduce transmissibility. But again, we are learning about this every day. One other big question is disease severity. So is this variant going to be less severe, more severe, or basically the same severity as Delta? I'll talk about that in one of the last slides, but it's probably too early to tell. And I think we need to, be likely more conservative right now and try to control this and try to not let it rip through until we know more. And then in terms of, the one thing, impacts of testing and surveillance, we do know that the same, testing, it will pick it up on testing. Rapid tests will still pick this variant up. And then the one good thing is that it does have S gene dropout, which basically just means that when they're doing in the lab variant of concern testing, it's easier to pick up. So instead of having to sequence the whole virus to confirm that it's Omicron, you can actually just look for that dropout gene. And COVID's been nice to us in one way, is that in that Alpha had the dropout gene, Delta did not have the dropout gene, and now Omicron has it. So if we're seeing changes in that dropout gene, it's easier to monitor before waiting for sequencing. So still learning more every day, but those are the main things that we're kind of watching. Obviously, how more transmissible is it? Is it indeed more transmissible? The disease severity, I think, is a big question. And then reinfection in people that have had COVID, and then also vaccine efficacy. Next slide, please. So these are just a few very pretty pictures, just showing all the different mutations that Omicron has. And when you look at it compared to Delta, certainly it looks scary that it has all these mutations, but more mutations doesn't necessarily mean bad. So it can, and so it's important to understand what these mutations do. And I'm not a specialist in specifically the specific virology down to the mutation, but from the reading that I have done, basically some of the clusters of these mutations have been shown to increase transmissibility, increase their efficiency of binding and entry into the cells, and then also decrease or cause increased resistance to monoclonal antibodies. So there are some trends here that do make us worried about this, but it's not necessarily the sheer volume of mutations, and some of these mutations may do things that make the virus weaker. So again, still learning. Next slide. I think this is just comparing basically the different variants that we've come up against, and you can see that Omicron has much more mutations than some of the other variants, but Gamma had fairly few mutations, and same with Beta, but they were still more, they were worrisome at the time. So it's important to put it in context and to stay calm and to keep understanding the data that's coming. Next slide. And this was the slide that I was kind of alluding to. So the scientists in South Africa are doing an amazing job of really tracking the cases, tracking the weekly share of positives, and then tracking hospitalizations. And so what we've seen so far is that the cases are certainly increasing faster, which is that expected to be some combination of increased transmissibility and ability to escape from known previous COVID infection. But then the weekly hospitalizations is really the question: is this going to translate to more severe disease? We know there's always a lag, so it's likely too early to tell. But even between 2 days ago and yesterday, when people were updating these graphs, there does seem to be a little inflection at the top of the Omicron wave in the hospitalization rate. So it does seem to be trending up a little bit. But again, I think too early to tell, and I think a lot of people are really crossing our fingers that we won't see it become more severe. And at least the hope is that if people are vaccinated, then it will decrease that risk of having to be hospitalized and having severe disease. So even more important, and so timely that we're introducing boosters, because even more important to get these vaccines into people, the people that haven't had a first and second dose, and then certainly get the boosters into people if they are above 50, immunocompromised, and certainly above 70. I think that's it. Next slide. So,
yes, I think that's it.
Perfect.
Thank you so much for that update. I wonder if I could turn it over to you, Dr. Moore, to just give us I guess an overview of how the province what steps the province is taking, and if you have any other messages for family doctors.
Oh no, that was a great review by Janine, and thank you. Yeah, it's a race to dampen the Omicron wave down within Ontario and internationally till we get some scientific clarity on just the questions that Janine posed. We really need to understand the severity of this and the potential for vaccine escape. What level of protection will our vaccines provide against this virus? I do think it will provide a level of protection. We just have to know and be able to quantify how much. And we'll get some of those answers in the coming days as they do more neutralizing antibody testing. But it is an aggressive battle that we're playing against it at present, just to tamper it down and further protect Ontarians. So as you may have heard, we had over 1,000 people arrive in Ontario alone from the 7 countries that were identified initially as being at risk. When they expanded the number of countries, we had an additional 1,832 individuals. So 2,832 individuals that were following at the federal level, that they are under federal quarantine. They're getting tested at day 1 and day 8, but we're already seeing transmission, as Janine has said, into the community. And certainly having an exposure in a detention center is quite disconcerting. We had 7 cases as of last night, and that number will exponentially increase in the coming days. The investigations are ongoing. The good news is as Janine has pointed out, we have a PCR test, the S gene dropout, that can give us an early warning of it being present in our communities as a marker of the presence, differentiating it from Delta. And then we have a robust whole genome sequencing, but the whole genome sequencing turnaround time can be 5 to 14 days, depending on throughput capacity. So the main piece now is to get the S gene dropout up and running at a provincial level and have it as our early warning indicator of Omicron. And from a public health vantage point, we are initially being more aggressive with the contacts of these individuals. So if you're a high-risk contact, even vaccinated, you will be asked to stay home. And in some congregate settings, we'll be dismissing a whole class and or testing a whole school if necessary, given the potential for cross spread of this virus. So we have created a very aggressive, I think, case and contact management capacity against Omicron and are putting that in play. We put it in play over the weekend. So I hope you're feeling confident that we have a testing capacity and epidemiologic capacity, and we're partnering, as Janine said, very well with our South African colleagues who've been so transparent in sharing the information with the rest of the world and helping us understand the threat of this virus. We do think some of the monoclonal antibodies will work. We also think that some of the oral antivirals that may be available to us in the first quarter of 2022 will work, but we need further clarity on that. So from a Delta vantage point, we all have to be reminded that the main threat to us, though, is Delta. It's 99.9% of the circulating strains right now in Ontario. We have 1,000 cases today. Over 1,000 cases today being reported, and those numbers continue to increase. But this is expected, given that we're heading indoors, and you're seeing what's happening in all the northern climates as we head indoors, close spaces, and crowded spaces. We're seeing increase in transmission, and Delta is highly transmittable. So our main weapon against that is the ongoing immunization campaign. And we're making great strides. I have to thank all of you that have been participating with advising your patients or working in any of the immunization clinics. Yesterday, we had 12.3% of those from 5 to 11-year-old immunized. And I'll just give you a couple of updates on the third dose strategy as it's proceeding. So for all of you who work in long-term care facilities, we're at 85.4% of eligible long-term care residents have had their third doses. So thank you for all of your work in best protecting our most vulnerable members of our community. That strategy is working very well. I would love to see that 15% immunized, but I'm sure we're going to get there. In terms of workers in the long-term care sector, though, who have had their third doses, we're at 26.8%. So please, if you work in the long-term care sector, please continue to advise about all workers getting their third doses. This is an effort to decrease the risk of transmission of the virus, the decreased risk of carriage of the virus into the workplace. Which is so important. For healthcare workers generally in the acute care sector, we're at 34.2%. So if it's 168 days after your last dose, we would really strongly encourage all of those workers to get their third dose to best protect themselves, their workplace, and their community. And for the Ontario population 70 and above, and you have a great opportunity to advise members of the community day in and day out, we're at 41.5%. So as you may have heard yesterday, we're expanding the third dose eligibility, but 50 years of age to 69 aren't able to book till December 13th or go into their local pharmacy or clinic. So we have a narrow window, what day is today, the 3rd, of 10 days to try to get healthcare workers, because we have capacity now. Those over 70, those that are immune suppressed, transplant patients, those that have had 2 doses of AZ, 1 dose of J&J, obviously they had to get that elsewhere, to have an opportunity to get their mRNA vaccine 168 days after their last dose. So this is really strong push right now to promote the third dose for those populations before it opens up to many million individuals in Ontario that would be eligible for the third dose between 50 and 69 years of age. And we'll monitor the capacity of the system and expand those age groups as we provide care to third doses to those individuals in a staged and phased manner, because we anticipate we have capacity for 100,000 plus a day throughput, and we're at 67,000 doses yesterday. And so we still have capacity to provide those third doses to those populations. So as risk communicators to the public and within your practices, please consider promoting the third dose strategy. I do think it's going to help us in the dark days of winter. It's going to further protect and decrease the risk of transmission. It's further going to boost protection against hospitalization and death. And that is our key goal, is to continue to protect the health system. I should mention that despite our case counts going up, our acute care sector remains relatively stable. So today we'll have 141 individuals in the intensive care unit settings across Ontario. That is a key number that I keep monitoring, with the length of stay being around 12 days. So these are younger patients now that are getting admitted to the intensive care unit. They have a higher probability of survival and discharge from the intensive care unit setting. The other metric, obviously, we watch is hospitalization, given that we have an ALC problem in the hospitals at present and bed capacity issues. So we're very conscious of the impact overall on admissions, but clearly want to monitor and protect our acute care sector. So the acute care sector bed occupancy is still at around 71%. We have capacity in case there's a surge related to Delta and or hopefully not from Omicron, but we certainly have that capacity. And on the pediatric side, we've only had 2 or 3 admissions to our pediatric hospitals across Ontario to the intensive care unit settings at any given day for COVID. And it's having, again, a smaller impact on that population. We certainly hope a broader adoption of the vaccine in those populations will prevent further hospitalizations. And its bed occupancy is in the low 80s or mid 70s on any given day. So we both have acute care and pediatric capacity heading in to a higher risk period in the winter. So Tara, is that a good enough synopsis of where we're at just on the immunization strategy? I think Janine gave a great overview of Omicron and the health system, and I gave a brief update on the expansion of the boosters.
Thank you so much, Kieran, and it's terrific to see, that we're prepared for Omicron from a testing and case and contact management perspective, and terrific to kind of see that capacity around third doses. I wanted to just build on, because I see a number of questions in the Q&A about the third doses. So, for example, Alan Grill asking, given waning immunity after 6 months and the data from European countries showing cases rising where vaccine uptake is similar to Canada's, why not open up booster doses to all age groups now? I think another physician later on, I think Carolyn said, yeah, I mean, I think basically she's also worried, grateful to have it over 50 open, but why can't we expand it to more now?
Oh, no, well, I want to assure our members of the Ontario College of Family Physicians, we will. But we have to do it in a staged, phased, evidence-based approach, which I think is all of our clinical practice approaches to medicine. We are seeing powerful and persistent immune protection in Ontario up to 8 months after the last dose at a population level. Our biggest concern is to make sure that we have availability for those high-risk groups over the next 10 days, and please promote them in your practices. And then the 50 and up as the next highest risk group to have an impact on the healthcare sector. It really goes back to what our goals are in the pandemic, is to minimize morbidity, mortality, impact on the healthcare sector. And this is the way we have to do it. We have to give the opportunity to get immunized in a staged, phased manner to best protect the acute care sector. As we see openings in the system and increased capacity, we'll lower the age group over time. And certainly it could be sooner than January if we have capacity, but we want to give the opportunity to get protected to the highest groups first. But I don't want you to think there's an immune cliff. There's no immune cliff. We're seeing powerful, persistent protection 8 months out through Jeff Kwong's work. We're also seeing that mirrored in BC and in Quebec. Our separation of doses has done a great benefit to our communities to have that persistent protection. And we're still at the 96% range of protection against severe outcomes, hospitalization and death with 2 doses at a population level. But with waning immunity in some groups, we're asking them to come forward to have maximum protection heading into the winter. And I do anticipate it'll have a protection against Omicron as Omicron becomes the dominant strain in Ontario. That I think that is inevitable. It's just we have to delay it to get further science to understand what therapeutics work and the exact benefit from vaccines, because that will advise us on what public health measures would be necessary to further protect the community and our hospital sector.
Thanks, Kieran. I think there were some questions about people particularly worried about teens and adolescents and their third doses and people who are university aged.
So they will not get a third dose. So that NACI will be coming forward today and making a statement that there's absolutely no evidence of benefit from 12 to 18 of having a third dose. The 2-dose strategy in that age group with the separation that we provided in Ontario is providing very good, robust immunity, and we have to just refocus our energies as protect the healthcare system, hospitalization. They will have still an ongoing benefit against transmission, and they do have a lower risk of getting hospitalized. For anyone immune suppressed in those age groups, we may be reviewing a third dose strategy for those populations, transplant patients, etc. But for the general population, we're seeing very good immunity with the 2-dose. And there's some nuances on the strategy, such as if you've just got a stem cell transplant, we will restart the strategy for those individuals and give them another 3 doses. And we may be giving a 3-dose initial strategy to immune suppressed, and then a 4th dose 6 months later. So all of that's coming out as we follow the science.
Thanks, Kieran. I think David had a follow-up question as well.
Yeah, hi, Kieran. I'm going to ask, as a guest host here, a bit of a pointed practical question. So many of us are immunizing patients with boosters in our offices, and especially with, the 15 doses and sometimes more doses, depending on, who you're vaccinating with Moderna, or even with, 6 doses of Pfizer. We reach the end of the day where we may have 1 or 2 doses or more of Moderna left. And given the announcement with regard to 50-year-olds, if it's 4:45 in the afternoon and I'm closing office for the day and I'm worried about throwing doses in the garbage of Moderna, should I be vaccinating people over 50 for a third dose? I mean, it's 10 days away. And I think it's just a very practical question for us, because we don't have the throughput of mass vaccination clinics, and it would be shameful, I think, for us to throw doses in the garbage.
Well, no, we don't want to see wastage. I think that's a very good point. As a provincial policy, I can't give you a comment. This is an open session, but I can understand the principles that you're adhering to.
Thanks, Kieran. And just to clarify around the teen and the 3rd doses, I believe if the person is Indigenous, they do qualify if they're 16 to 19 for the 3rd dose.
16
is that
and
right?
up, correct.
16 and up. Yeah, perfect. So I know, Kieran, you do have to leave. I know there's more questions for you, but if you do have to leave,
I'll keep on until Daniel comes and we'll do tag team. How's that?
Okay, all right. So these are questions for both you and Janine. So I think the top question here is there any new data regarding rate of transmission in fully vaccinated people, whether symptomatic or not? So this is either for you or Janine to speak to.
I just want to say it's clear in the limited number of cases we've had here in Ontario, many are vaccinated, they're asymptomatic, and they are carrying and transmitting back to family members. So we're seeing that here. So it's clearly happening in other jurisdictions, and I think we'll have strong evidence of asymptomatic carriage despite 2 doses of vaccine, and the potential ability to transmit. It does seem highly transmissible.
You're talking about Omicron, right?
Omicron, correct.
Yes, but how about in Delta?
And minimal symptoms. Oh, absolutely can happen in Delta. It just, from my limited experience with Omicron, with the that we're currently investigating, absolutely seeing it. And rapid spread.
Yeah. So just to distinguish, so with Omicron, for sure, we're seeing it. For Delta, is there any new data about rate of transmission in fully vaccinated people, whether symptomatic or not?
Oh, you carry a very high viral load. If you get symptoms despite being vaccinated, you absolutely can transmit it. It does seem to be a shorter window because you have a good antibody response from your immune memory and can bring that viremia down more quickly than someone non-immunized, but you absolutely can transmit if you're immunized and get Delta.
Thanks, Kieran. So the other question we've touched on this one already. Ruma Chowdhury asked how effective are mRNA vaccines against Omicron, and I think we discussed that we don't know at this time. But I think Ruma's other question is: are we looking at every year COVID vaccines for all from now on?
Oh, it's a lot of unknowns, and we're going to be following that science. Whether we chase the strain and constantly have a spike protein vaccine, or whether we look for something more stable on the coronavirus, like the nucleocapsid vaccine, because it seems to be mutating at a less frequent rate than the spike protein. So there are a lot of unknowns in that question. I think we need a more stable protein, given the rapid change we've seen. Otherwise, we're chasing it like we chase influenza every year, having to modify it and modify it and modify it. But with the mRNA technologies, we do have a rapid turnaround time. It looks like if we needed an Omicron-specific vaccine, we could have one in 100+ days. It would need to be manufactured and then distributed, so they have to put that time frame in as well. And I don't want to over-comment on science. Janine might have expertise on. So, Janine, did you have a comment on that?
No, I think you nailed it. I mean, I think that's exactly it. I mean, the hope is that, and also I think we also don't know, a lot of people are saying, you know, maybe this is a 3 vaccine series. So we also don't know with this 6-month interval, how good this immunity is going to boost. And if it turns, even if people are still able to get it, but they don't get severe disease anymore, you know, that's really the goal, right? So I think that time will tell. And I agree. I mean, I think if there, you know, is an ability to find something more stable that you can put into a vaccine, that we won't see mutations as often, you know, or when they come out with the next version. I know Moderna is working on different versions with new variants right now for boosters, then we can see how those things evolve. But yeah, no, completely agree with everything you said.
Great. So Jenny Clement has asked a question about flu shots in the COVID vaccine for kids 5 to 11. So we know in adults, of course, those can be given simultaneously, but that NACI recommended that these not be given within 14 days of each other. Jenny's writing, it's causing a lot of confusion in our office, and I'm telling parents that it's only because we want to make sure there's no side effect from flu shot attributed to COVID vaccine, not due to concerns about vaccine effectiveness for either shot. Please confirm this is a recommendation and not based on any concerns about the effectiveness, i.e. if parents get this, then they can have the flu shot prior or after COVID within 2 weeks.
I think she's absolutely right, and that's a very good point. It was mainly a concern about us documenting appropriately adverse events following immunization, and thank you for filling out your adverse event forms. That really is helping us monitor the safety of both vaccines, and it was absolutely precautionary. It wasn't any interference with the ability of the vaccines to promote an immune response.
Thanks, Kieran. And I will say, I gave my own kids the COVID vaccine within 14 days of their flu shot, and they're doing well. They're doing well.
Great.
I think, so Alan Grill has a few questions here, but I'm going to ask the one just about this one, which is a topic we haven't touched on yet, which is, he asked, will free take-home rapid antigen tests and or PCR tests be available for the public at pharmacies heading into the holidays? So it might be, you know, I know you guys have a great winter testing strategy, Kieran, so it might be terrific to kind of just hear some highlights of what will be available.
So I did have concerns that the rapid tests weren't going to be effective against Omicron, and we're working with the manufacturer to further understand that, given all the mutations that have occurred. But we've been told that the BTNX, the one that we purchased for all students across Ontario, is looking at a antigen in the nucleocapsid. In that area of the nucleocapsid is remaining very stable from a mutation vantage point. So it is assumed, given our conversation with the manufacturers, that the BTNX, so we're giving out 5 to every child in Ontario for the holidays, Monday and Thursday, testing sequentially, because we know serial testing with rapid antigen tests is the most sensitive and specific way to go. We think it'll help identify Delta as well as Omicron, and be very beneficial for a safe return to school in combination with the robust immunization strategy we have for 5 to 11. So rapid antigen tests, at least for the PanBio and the BTNX, we think will be very will be sensitive and serially specific for both Delta and Omicron. And we're, you know, that was a huge purchase for us to have 5 for every student in the province, over 11 million tests. We're looking at purchasing further to make them more available through drugstores as well, as a means of having increased testing across Ontario into the holidays. So I absolutely agree. Part of this discussion was about the holidays. I absolutely agree. We as communicators to our practices and to the public have to show our concerns. In some areas of this province, the social numbers allowed are down to 10 indoors and 25 outdoors due to the spread. So I think, you know, the communities where we have high rates in Sudbury and Algoma And in Kingston has one of the highest per capita hospitalization rates right now. The Southwest has high case loads as well. And in those areas of the province, they may be limiting the number of the people in social gatherings. And that would be, please check with your local public health agency if that changes and be able to risk communicate that to the public. As well, we know going indoors in crowded spaces and when people take their masks off is a high risk time for transmission. We have to be communicating that as a risk to our populations that we serve going into the holidays, especially if Omicron is about to take off. So we'll have to stay connected. Tara, I'm happy to come back as we get closer to the holidays to give further risk communication that can enable you to communicate to your practices. But it is a high risk time for us. And you'll see many risk communicators, the Isaac Bogoshes and the Peter Junies coming forward to further communicate. Get your third dose, be careful over the holidays, limit your number of social contacts, especially as we go indoors. And it may be across the province in some areas that it's 10 people indoors to decrease the risk. And I'm so happy to see Daniel here join us. He can brief me on the last meeting.
So thank you.
I'll stop there. Yes.
Thank you, Kieran, so much. I think you did a great job answering that question. I think the other part was around the PCR tests and availability at pharmacies. I don't think you spoke to that, but maybe I missed it, but it was I think there are take-home PCR tests that will not self-administered PCR tests that are potentially going to be available at pharmacies for pickup and drop off. Is that right?
I'll have to maybe hand that to Daniel. So I know they do them at the pharmacy, the PCR tests, and they'll do the rapid antigen tests. I don't know if there's take-home yet.
Okay. I know Janine has organized those for schools in Toronto, and I know many schools do have them across the province.
Yes, most schools have a take-home in case there's a high-risk contact.
Exactly.
And we want the PCR as the initial test for any high-risk setting, any outbreak. It's going to be PCR. Rapid antigen tests are only for surveillance testing on a longitudinal basis. That's their strength.
Thank you so much, Kieran. And I understand if you have to drop off, so thank you.
Well, I'm enjoying myself, but I like to have Daniel as a tag team partner.
Daniel, could you speak to that of PCR tests being available at pharmacies for take home, or is it just in store? I actually thought I read that in the province's winter testing strategy, but
yeah. So there are some pharmacies that will have available for pickup for self-administer, then drop back off. I'll be honest, I'd have to go back and check exactly where that rollout is in the province. But there's also, of course, the Lucira test that's available over the counter that you can purchase. That is a molecular test that's available in pharmacy that people can use if they want that as well. So not that we're promoting, buying that one. You should be going and getting the test that's most appropriate for you. But there's a variety of options available depending on exactly where you might be.
Great. And it does sound like, and Kieran and Dan, you can nod here, is that all kids in grade school and high school will be given those rapid antigen tests before the holidays?
Correct.
And yes, so that is correct, because somebody asked a clarifying question about that. Now someone's asking private schools too? Yes.
Oh, Daniel's saying private schools, okay.
Private, yes, private schools are getting the rapid tests. But it's different for some of the take-home PCR testing, what's available through the private school system.
Okay, great. So I think there is a number of other questions. I also know, though, that Janine was going to just go over a little bit related to kids and the vaccine. So I wonder, Brian, can we bring up maybe the third dose slides, actually, and then we'll just flip through those quickly and then get to Janine's slides. Yeah, the next slide. So again, we'll circulate these slides again, but it's just a reinforcement of what Kieran said, that these are the individuals who are currently eligible for their third dose, and the big change is that effective December 13th, 50 and up will be eligible. Next slide. People who are immunocompromised are eligible 56 days after their second dose. And the new change here is effective immediately. Those receiving dialysis are eligible for the third dose. Next slide. This is also new, so there is a recommendation for revaccination with a new COVID-19 primary series post-transplantation. And so there's some very specific pieces here. And again, we'll post the slide so you can review this. Next slide. Next slide. And then I'm going to turn it over to Janine to maybe just tell us a little bit, I think, around, I know we're supporting kids to get vaccinated, all of us, but I will say I've personally got the sense that there are many parents that are waiting because we see that the clinics aren't quite as full as they could be. And maybe, Janine, you could talk to us about some of the communication and other pieces related to the rollout.
Perfect. Thanks, Tara. So next slide, please. So certainly we have found that. I mean, we've been doing clinics here in East Toronto, just on our small scale in both schools and our larger vaccination center. And the school clinics, we've really prioritized the areas with higher priority who have been hit harder by COVID. And unfortunately, there is, despite all of our outreach efforts, there's less people coming for vaccine. And so it's probably a combination of factors, but really, I think the things to highlight, and when I'm speaking to parents, a lot of them still think, because all the messaging throughout the pandemic has often been kids don't get very sick, kids are okay. So I think now it's kind of resetting that even though we're very lucky that most kids do not get severe disease and most kids are fine, there's still a huge important part to protect kids' health and to protect their families' health, and then obviously to protect them from having disruptions in learning and disruptions, with other activities. So this, I think, really hits home in terms of the spread of COVID. I did a small group session last night for a group of moms, and they were like, well, kids don't even really get it. But clearly we've seen, within the province that this makes sense. The group that is all unvaccinated, all gathering together, going to school, participating in different activities, the rates of COVID in this 5 to 11 group are far higher than any other group in the province. And certainly we are seeing, that trickle also into their families, their parents, and then into likely over the holidays, without further mitigation, into their grandparents. And so again, it's not going to just stay in this group, and important to provide vaccinations for them so we can see this number come down. Next slide. And this really reflects that. So the green line here are outbreaks in school situations, and they're primarily in elementary schools. So this is all schools together. And you can see, the wave last year before March break and before schools shut down, obviously was higher than where we're at now, but the trajectory of this makes me quite unhappy, given that, we're in a situation where we still have 85% of the people 12 plus vaccinated, but we're still seeing these significant outbreaks in schools. So really being able to get good penetrance and vaccination into the 5 to 11 group is not only going to make them safer on an individual level, but is really going to help to provide protection to the schools and prevent a transition, back to online learning, which I know nobody wants. And so to really keep kids where they should be in the classroom. Next slide. And I think from talking to parents, again, it's COVID is rare to cause death in children, and that is a good thing. But we have had 17 deaths in Canada, less than 19 years old. And I think this slide to me puts it in perspective about, why do we vaccinate? So we vaccinate to reduce morbidity and mortality, and to reduce the spread of these diseases. So in the United States, from October 2020 to 2021, there were 66 deaths in the 5 to 11 age group from COVID. And if you look at illnesses that we routinely vaccinate for, the number of deaths in the years prior to when we vaccinated them were a fraction of what we've seen from COVID. And I think now with Omicron coming, we don't know, if there's going to be increased severity of illness, but certainly there likely will be increased spread from what we've seen so far. And if that's the case, then kids are going to be more likely to get it. And if you just have, in terms of sheer volume, if more people are getting it, some of those people are going to get ill. And the thing as a parent, and hearing from, some of you probably that do emergency department medicine have seen this too, that the cases that are very scary are the children that present with multi-system inflammatory syndrome. So, unpredictable who's going to get that. It can be 2 to 6 weeks after their acute illness with COVID. It's about 1 in 3,500 cases, but those children, about 60 to 70% of them end up in the ICU, and 1 to 2% can actually die. And so fortunately, we have not had, the sheer volumes of cases in Canada, but if we continue to open up and see more kids exposed and get COVID, we may see those numbers trend up. And so, I definitely feel strongly that I think this should be something we're all working towards. Next slide. So this one is just to illustrate basically the number of doses that have been given in the United States. So you can see that they have vaccinated at least one dose, 14.2% of the 5 to 11s. And so as of a couple of days ago, that translated to 4.2 million first doses of vaccine and 320,000 second doses. So that's amazing. I mean, we never intended for them. It was not intentional for them to be ahead of us, but I think that really helps in terms of those conversations that this is real life data. There was about 3,000 children in the study that got the COVID vaccine, but now having literally millions of children receive it with no safety signal showing from the United States is very reassuring. So NACI and Health Canada are in constant communication with CDC. And from everything that I've seen so far, there's been no indication of any adverse events and no signal there. So obviously with myocarditis, they're going to be watching that very closely and need to follow after the second dose for several weeks. But the benefit we have here is that because I think, totally appropriately, NACI recommended that 8-week interval for the doses, we're going to have basically 2 months of data with millions of children that we're following in the United States before we start those second doses for our kids. So we'll have a really good idea of if there is an increased risk of myocarditis in this group and what that risk is. And so far, 3 weeks after those 4 million doses, no safety signal for myocarditis after first doses and no other unexpected side effects. So very reassuring in the real world. Next slide. So this is just to illustrate that interval that we're talking about. So Health Canada did authorize the use for 21 days, and that's because the trials were done that way. But NACI has recommended this 8-week interval, and really there's kind of multiple reasons for that. One is based on Jeff Kwan's data and other data that is available from other jurisdictions, basically showing that if you space out that interval, that there's a better and more robust and likely longer lasting immune protection. We just heard Dr. Moore mention that for the 12 to 18 group. So really that those 2 doses spaced out will protect them for longer. And that makes good sense from what we know about a lot of other immunizations and how our immune system works. The second reason is there's some yet unpublished data, but it's kind of apparently in preprint form, should be coming out soon, that showing that extending the dose interval actually may also reduce that risk of myocarditis. So even if there is a small risk in this age category, it'll further reduce that risk. So really those are the kind of the 2 main reasons leading that. And I think it is definitely appropriate, makes sense. And even before I heard the NACI recommendations, that's what I intended to do for my own 2 little munchkins that are 4 and 8. So I fully support this recommendation. Next slide. So this is just, we get a lot of questions about kids at the margins. So kids that are, 4 turning 5 and 11 turning 12. So this slide really breaks down the immunogenicity within the study. So lots of numbers on here. The important parts are that, at day 1, those were the baseline and antibody levels. And then at 1 month post dose 2, those were the antibody levels. And so they compared these antibody levels to the 16 to 24-year-old group to ensure that they were reaching a level that was appropriate to provide protection. And so what they saw in the study was that the 5 to 6-year-olds had equivalent and good robust immunity to the 7 to 8 to the 9 to 11. So if you have a child that's 11 turning 12, that you're counseling for parents, don't wait. So recommend that they get their first dose now. And especially with Omicron and the rising numbers and the holidays, I would certainly recommend, even if you turn 12 in January, get your first dose now. Those children can get the 10 microgram dose. They may even have a lower risk of side effects with that dose. And then once they turn 12, if it's within those 8 weeks, they can get their second dose of the adult dose at the 30 microgram dose. And potentially, they may have a lower risk of side effects with that, and they also will have robust immunity. And I think the thing to remember about vaccines is it's based on the maturity of your immune system. So the child's age, the maturity of your immune system, not based on their weight or their size. And same thing at the other end of the spectrum. So if you're 4 turning 5 within the next month, so in 2021, those children are eligible to go now. And it's, again, not based on size. So I have a tiny little 4-year-old who's 5 in like 10 days. She was a preemie, she was 28 weeks, and she's about 23 pounds, and she got her dose last weekend. She did just fine, and I had no hesitation giving her that same dose as the older kids, because she would have qualified for the trial in that age group. In terms of the people that are turning 5 in 2022, I think we're yet to hear, so far what I've heard is they have to be 5 for that dose, but I think we'll see if there is any shift to allowing, an interval or within a few months if you're turning 5, or what the plan is. But as far as I've heard, and Dr. Moore and Dr. Warshafsky can correct me, but they're right now they have to be 5 if they're turning 5 in 2022. And there are new studies still ongoing in the under 5 group, and the hope and the expectation is that those will be available kind of for Pfizer late this year or early 2022, and then same thing a little bit later in the year for Moderna. And so hopefully that they'll submit them to Health Canada, they'll be reviewed, and then I'm hoping kind of early spring, late winter, kind of March-ish, but that's just a rough estimate based on the expectations. And I believe that is the last slide, so I'll hand it back to you, Tara.
Thanks so much, Janine. A few follow-up questions. I think there's a question about the interval of dosing. So a couple of people have asked questions related to that. So Alan Grill said, do you think we can roll out, this is the wrong one. Laura Pripstein asked, patients are asking whether it would be unwise to get a second shot for their kids 5 to 11 sooner than 8 weeks to align with their travel. For example, if they get it when in the States while they are traveling. And then Jennifer McCabe said, will there be any consideration to shortening the doses for interval for kids 5 to 11, given the emergence of Omicron?
Do you want me to take a stab, and then you guys, Dr. Moore, you can fill in anything? From what we know about the science, I think the 8-week interval makes very good sense. So we know for children that it's very rare for them to have severe disease or complications. And so one dose of the vaccine, it's not going to provide them with a bulletproof vest and prevent any infection, but it would also significantly reduce that risk of severe disease. So even having one dose for them is going to, make them safer on a personal level. And extending that dosing interval is going to provide them with protection for longer and reduce any side effects for themselves. So I think on an individual level, the 8 weeks makes good sense. Just to get it because it's convenient or based on travel, from an individual level, I don't think it's, the best plan for children. Would it be fine to get it at the 21-day interval, and would the child have any harm? No. That's when they did the studies, and that's what the United States is using. So it's not, I don't think it's unreasonable to do that, but I would recommend waiting the 8 weeks. If we see large surges and then the data changes that we are seeing, children more impacted and getting more severe illness with Omicron, then I think that would be something that would be reassessed. But I think that the recommendation from NACI makes good scientific sense and good sense in terms of best protection for individual kids.
I think, I think there is a follow-up here almost that parents want to avoid missing 14 days of school upon return from their holidays. So perhaps that's part of the reason that they want to have their kid being fully vaccinated prior to leaving. I don't know, Dr. Moore or Daniel, whether you guys have any additional points from what Janine said. Otherwise, I do have a few other questions I'll go to. I think the other question here that's being asked is, when can we expect vaccination in kids younger than 5? I don't know if any of you are able to speak to that. And I think partly this is also a health system planning in terms of getting ourselves ready and where that might be happening.
And you might be able to provide an update on that. I don't think they've submitted to Health Canada yet on the 6 month to 4 years yet. So
No, yeah, from what I've heard, the hope is that by the end of this year, so late December 2021, the last I heard from NACI is that's when they're expecting to hear from them. And then it will take at least a month to review the data. So I think at the earliest, it would be February or March that we would see. I think that's the rough timeline that I've heard kind of thrown around.
Okay.
And I think this was a related question to kind of what you mentioned about the, keeping an eye on the data, Janine. So Alan Grill asked, it seems more kids in South Africa are being admitted to hospital with the Omicron variant. Are you concerned this could happen here? And if so, do we have the pediatric bed capacity to handle this? So I don't know, Janine or Kieran, or if you,
Well,
Kieran, it looks like.
number one, I'll just respond that we've built extra pediatric ICU capacity, and we did tabletop a vaccine escape variant during the summer, and worked with our pediatric colleagues, all the pediatric hospitals, and again, they're at 75% capacity with the current bed structure, and they can expand that by an extra 30 to 40 beds if necessary. Plus, adolescents, if they get sick, could be treated in adult, and we certainly have capacity in the adult side. So we're absolutely watching the data from South Africa, in regular contact with the South African public health officials, epidemiologists, virologists, immunologists, and that I'm really impressed by the dialogue that we've had with them to understand the situation there. And certainly I'm concerned about any impact on children that would change our strategy. We've been blessed, as Janine has said, that Omicron, well, that Delta has had a low impact relative to the older population on our children. But I will say that we had 300. I just got the, as Janine was saying, the multi-inflammatory syndrome case numbers, 301 MIS cases to date across Canada. So that is another complex issue that we have to deal with, and immunization should decrease the risk of that. Certainly not much mortality, but that is disconcerting to see the total number of cases. So the immunization strategy should decrease that risk as well.
Thanks, Kieran. I guess the last question I'll ask is just about, our health system capacity to do all of this vaccination. So we're thinking about third doses, 5 to 11. And I think my colleague Alan Grill and others have asked, is it really, can we do this in an appropriate time frame, given a number of our mass clinics are down, hospitals are not really in the vaccine business anymore, and primary care is much busier with other priorities?
Yeah, so public health is taking on a big proportion of this. So are our pharmacies, and the throughput in pharmacies. We've been having ongoing negotiations. I think will increase dramatically. We do anticipate being able to immunize over 100,000 people a day, and we're not. People aren't coming forward enough. So that's part of the discussion today, is asking you to be involved with advising your patients on anyone as they become eligible. The capacity is there at present. Please go forward and get your doses when it's time. 168 days on average for the third dose. That's why I very much cherish the opportunity to speak to my colleagues in the Ontario College of Family Physicians, and thank you for the opportunity to speak today.
Thanks, Dr. Moore. So just as Brian gets up our last slides, I'm just going to read out this comment from Emma Smith. She says, I just want to thank you to all of the speakers, but especially Dr. Moore, for their great discussion today. The messaging from Public Health Ontario, and I think she might also just mean the Ministry of Health, has been much more direct and helpful to me as a small town family doctor since Dr. Moore took the reins. So thank you for your work. I think we're all really grateful for that leadership that you're taking at the province. Stay tuned, guys. We have one more session coming up for our community practice before the holidays, and then in January, stay tuned for Family Medicine Summit. You can register now. Next slide. Just a reminder of our COVID vaccination modules that are available. We actually often include relevant clips from these community of practice sessions in the modules as well. So it's a great kind of overview and a great place to look up new resources. And we didn't have time today, but we have in some of the slides some terrific new resources as well. So take a look at those after the session. Next slide. So as usual, our session will be posted. Usually the recording is posted the same day along with the slides at our website. You can share those with colleagues. And we are coming back on December 17th. We'll ask you in your evaluation to tell us what you want to hear about next time, what you want to discuss, what questions you have. If you have any speaker recommendations, we take your recommendations really seriously, and they help us to plan our sessions. I do want to give a really special thank you to our panelists today, who I think fielded a lot of really tough questions in a really tough, ever-evolving environment. So thank you, Dr. Kieran Moore and Daniel Warshafsky from CMOH office. You guys are so busy. Thank you for making the time. Thank you, Janine McCready, for coming in and preparing. I know you're doing talks all over the place, and so appreciate you fitting us in, and thank you for all your leadership regionally as well and beyond. And thanks to my co-hosts, Liz and David, and all of our team behind the scenes. And thanks to you for the amazing work that you continue to do. As Dr. Moore said, you know, we have a huge role to play in getting that messaging out to our patients around third doses, around vaccines in kids, and around the safe gatherings that can help to keep us all safe as we see Omicron start to arrive here in Ontario. So thank you for all that you do, and we'll see you here again in 2 weeks.
Thanks so much.
Thank you.